The Trust has decided to pursue Virginia Mason's production system, as they call it, which I gather is based on the Toyota methodologies, which are called Lean. But there's a lot of similarity with the productive series that we're familiar with in the NHS anyway. But they talk about there being 7 wastes. They talk about wastes in processing, where you do more than is necessary, or you do processes inefficiently or ineffectively. They talk about waste in terms of motion, so perhaps the patient has to go to another unit or another ward in order to receive a treatment or a test or whatever. They talk about defects, where the process does not lead to the required outcome, basically. But one of my favourite phrases that I've learned from this Lean consultant is about correcting failure. How much of our time in services are we having to spend redoing or recalculating or representing data because it hasn't been done in the way that we need elsewhere in the system? Huge amounts of time spent on that. In terms of transportation, it might be notes having to be moved around for community services, for example. In terms of inventory, I think the example most people will be familiar with is the idea for cars, garages, servicing cars, the just-in-time theory. They no longer keep lots of spares, they order them in just in time, so they save themselves a huge cost there. I guess for us, these days it's about perhaps having staff with different skills to the skills we need right now. Overproduction is doing more than is necessary, or doing things that we aren't actually paid to do. And I think there's a real challenges to us as professionals who have a traditional way of doing things and our professional preferences that actually may lead to overproduction. And then in terms of time, delays in the process, and things taking too long to do. So the system that this system looks at adding value, and activities value added if it takes something and transforms it into something that meets customer needs. The activity is done right first time. That's a big phrase that's used, and it's what the customer wants, really. So the idea is to maximise the value activities, eliminate waste, and reduce the amount of time you spend doing all the things that don't actually add value to the service user. You do that by understanding the demand for the service, understanding what you currently do, look at how you remove the waste and create better flowing processes, make sure things are very much about being pulled by the customer's, service users' needs, and then that cycle of continuous improvement. I don't think it's very different from what we all look to do anyway. It just has a series of techniques to help with it. There is a value stream map for the whole of the 12-week multidisciplinary assessment. We wanted to look for psychology. Obviously it's a limited resource. You want to be targeting it most effectively in terms of the number of assessments you do, availability to provide one-to-one treatments, group treatments, and the supervision, the training, the support of other people who are providing psychological interventions. And of course the MDT need the psychological formulation and opinion early on in order to inform the care planning by week 12. So it was, how do we do that most efficiently? And we worked through the process of the process mapping to work out exactly what we needed to do and where we were building in waste. To my shame, we've got it down now to doing it in 12 weeks. There were times when it was taking up to 32 weeks to do, because we were juggling lots of things, and then there'd be so much waste because you'd stop doing one thing to go and do another priority, and then you'd have to reread all your reports and try and remember where you got to, or something had changed for the service user, you had to go back and see them and add that in. So by the process not being smooth, we were actually adding in lots of repetition and waste, which hopefully we've now ironed out, and we're monitoring that, and we'll see how we go. What we're also doing is targeting it more to the needs of the service user, because there will be some service users who don't need a terribly detailed psychological assessment that takes 40 hours to do. For some people, a short assessment early on to inform the care pathway and the interventions will be sufficient. So why it's overproduction if you do more than that? You can then target the time you've got on the people that need a much more intensive assessment. And the other thing we are doing is making the assessment, the psychology assessment, more strengths focused and with more attention to the service user's perspective and service user engagement, to try and strengthen that element of the assessment. I did a literature search and realised there was very, very little out there on reducing length of stay. There's lots of policy statements, and even the benchmarking of length of stay is quite hard to get hold of. What seems to reduce length of stay is family connections and engagement. Actually, it says engagement in psychological work and group activities. So those are things for us to think about. In terms of my shared pathway, well, of course, the pathway describes what's required as the service user goes through the service, particularly in the early stages of admission, with those clear timescales, which is very helpful. But then, of course, I think what we think about most are the workbooks. And we know there's a lot of evidence out there that service user involvement in their own care planning and that ownership, that improves outcomes. I don't think there's any evidence out there at the moment, research evidence, that it actually reduces length of stay. So while the mile shared pathway, absolutely rightly, is designed to enhance service user engagement and involvement and ownership, I think we've got to wait and see, will it reduce length of stay? Because if you look at it at a very crude level, from the professional's point of view, it's much quicker just to tell somebody than for any of us to have a chance to actually have the time to sit and work through what does this mean for me. Professionals have had lots of experience of this service and the process. It's new to somebody coming into the service, and it's going to take longer in the short term. And I think what we need to be doing is looking at some evaluations, some research to say at what point in engagement does the balance tip, and thereafter it actually speeds things up. And what enhances that? What more can we be doing to enhance that engagement at an earlier, and ownership at an earlier stage? This isn't published, but it was just Dr. Novati, who's a specialty doctor with us, raised this as clinicians' impressions about things that increase and decrease length of stay, which I think are food for thought for us in terms of early identification and management of side effects, recognition of comorbid conditions, the physical health pathway, perhaps thinking about that, thinking about the relaxed signature. Is there more that we could be doing there? And then crucially, this last one, he labelled it as compliance, but actually that engagement and ownership with treatment. What do we need to be doing to enhance that further and to bring it earlier into the pathway? I'm going to leave that. I think that's the time to stop. Thank you very much.